Okay, I'm here with Sam Atwell, who's the Policy and Research Manager at the Health Foundation, and I'm going to talk to you today about, well, a range of things, but included in that is some research that you're doing with Randure on caseworker management. But before we get into that, Sam, tell us about the Health Foundation and your role there to set the scene. And also, I guess I'm also interested in what you're looking for here today and what you're doing here today at the event.
Well, thank you so much, Ben, and really, really great. Thank you so much for the invite to come and speak to you. So yeah, I'm Sam. I'm from the Health Foundation. I'm very conscious that lots of the people who be listening to this might not have heard of our organisation, but we are an independent charity. That means we're not politically affiliated. And we work to build a healthier UK. So that means working on how do we improve our health and care services, but also we're really interested in how do you sort of build health generally and reduce health inequalities. And I think our specific interest in work is that work is what we call a building block of health. I think I don't need to convince anyone probably listening to this that the way that we work, where we work, how much we get paid for our work are all really important things in determining our health. And of course, it works in the opposite way as well. Our health conditions affect the types and the amounts of work we can do. So it's a really important sort of work area for us. And I can definitely say a bit more about that. Really pleased to be here at the conference in Birmingham. What I'm really interested in doing sort of after this is speaking to lots of the different providers and understanding a little bit more about the services that they're offering employers, how they work with employers, what they think is really working well for employers. Those are the questions I'm really interested in.
Yeah, because you get it's such a big ecosystem and such an integrated ecosystem, and you actually at a conference like this you do get the whole gamut of providers, of funders, and of course employers here. So it has been a real melting pot. I was here yesterday, and I was really pleased to see how buzzy it was and how the kinds of conversations that were happening around the room. So talk to us. You've given us kind of the overview of the Health Foundation. What are you guys focusing on at the moment? Like what are your priorities this year? And I think particularly in relation to the workplace, as you mentioned there.
Well, I think it's the best way to sort of give a sense of our priorities, talk a little bit about the work, where we've got to recently. So about 2 years ago, we set up something called the Commission for Healthier Working Lives. And what that was about was really understanding what we call the UK's working age health challenge. Now, we're a data-led organisation, so I'll throw some stats out there. But last year, there were 8.7 million people in the UK, working age people, 16, 64-year-olds, who had what we call a work-limiting health condition. That's a health condition that limits either the type of work they can do or the amount of work they can do. This has gone up quite significantly over the past 10 years. If you go back to 2015, this was only 6 million people, so 2.7 million more people.
It's a big part of the economic inactivity
and it's agenda. A big part of the economic inactivity agenda. But also what we found, and what's I think really important, is that as well as sort of more people being out of work because of health problems, what we've really seen over the past, and it's a much more ignored trend, there's far more people in work with health conditions, just a shade over 4 million people in work with work-limiting health conditions. So what that really made us focus on is, well, we've got all these people who are in work with health conditions, and we've got this problem, that is sort of in the news around economic inactivity. There's concerns about the welfare bill. What we really thought we wanted to do was to reframe the debate, rather than sort of focusing on people who are out of work, who it's important to support. We also need to sort of be able to stem the flows from work into economic activity. Exactly. So prevention. So the work, the Commission Healthier Working Lives, we published a report last March, setting out what we thought would really sort of shift the dial in terms of stopping people falling out of work, which we know is actually bad for people's health. It's also bad for the economy and something generally to be avoided.
And what were the main strands of that?
So I think what we did is we sort of looked at the UK system in comparison with lots of other countries, places like the Netherlands, places like Denmark. And I think what we really found was that if you are unwell in work in the UK, there's a much higher likelihood that you can sort of slip out the system without getting the type of preventative help that you need. So this sort of starts with the things that employers do themselves. But as people listening to this will know, there are lots of things you can do that private providers can do, that the government can do to actually support employers to be able to help people retain people when their health conditions emerge.
So this is all the reasons why Keep Britain Working was needed, because that's already happened, but you're trying to look upstream to to say, well, there's got to be a preventative piece, that if you're going to solve that problem, we can't be just focusing on getting people back to work. We've also got to get the stay in work piece right, so it doesn't become impossible to solve.
Exactly. So Charlie Mayfield's Keep Written Working Review, which reported in autumn last year, was also looking at this problem. We worked quite closely with this, and it actually ended up in a similar place to that review. So what's really needed is what we called caseworker support, what the Mayfield review called case management support. And again, lots of people listening to this will know what that means, but really what we see it as is when someone becomes sick or starts developing health conditions in the workplace, can they get fast access to expert advice that intervenes early, that identifies what their real needs are, their health needs, but also the wider needs they have, triages them to the right types of support, and also works with the employer to help implement adjustments and keep that person in the workplace.
Okay.
That's the missing gap in the UK system.
Okay. And of course there are examples of that in the UK system, but it's not necessarily it's certainly not a universally successful or integrated with health services approach at this point. So I guess full disclosure, while we're talking about this, with my RAND hat on, my RAND Europe hat on, we do work together on a project relating to this, don't we? So, and I guess that where that's coming from is that, so if you identify one of the strands in your original research as being around caseworker models and caseworker processes, and you've commissioned work to look into that. Is there?
Exactly. So our sort of original work highlighted the need, and sort of using, for like in examples from overseas, this is what seems to work in other countries. This seems to be the major difference between other countries that are doing well in the UK. What we really wanted to do is to understand more about two things, really. So one, well, what are the principles? What are the ingredients of an effective caseworker approach? And part of the reason that we don't have that sort of written down anywhere is that there are lots of examples of good practice, lots of private providers and employers doing really interesting things, but that data isn't always available. And also the government has at times tried different things, but often that hasn't sort of achieved scale. So we've sort of learned some bit part things from different programs, but we haven't been able to sort of collate it all together into a full recipe for what an effective case management approach could look like in the UK context. I think the second part of what the project we're working on together is trying to understand not only what does an effective approach look like, but what are the wider sort of conditions that can help that approach scale. So again, reflecting on what happens in other countries, it's not just that there are, more providers that doing this type of work, employers are more interested, is that the sort of the legal system, the regulatory system, the electoral system, the incentives tax system are all geared around making sure that employers have that type of support available to them, and employees too.
And what's your view? I mean, this is what you hear this challenge around this all. I heard it in particular thinking about the kind of conversations we've both been involved in with Charlie Mayfield and his team. They obviously went and looked at places like Denmark and the Netherlands, and those. To a degree, and it wasn't measured, I think, the way they did it. They held up those systems as being, ones that were further on than ours, and that had, I think one of the things about it was that they'd taken a more strategic, long-term approach to it, and it probably started the planning for the system that they've got to now over 10 years ago, and have through successive governments, they've stuck through it, probably because of the, as we mentioned there, the tendency to have more consistency and in their governments, and they don't switch between extremes so often. So what do you think what can we take from those systems, and what can't we? Because we're clearly, well, we may be moving more towards hung parliaments, but we don't know. If we looked at the last 50 years, we're not. What are the limitations in our systems, and what are the opportunities in our system?
Well, I'd be lying if I sort of told the listeners that I'm an expert on the Danish electoral system. But I think, the first thing, the absolute sort of key lesson, I think, is what you said at the beginning, is it's a long-term strategic approach. So what we kind of know about labour market change, so big changes to the way the labour market functions, the way that employers function, the way employees interact with work is it is possible, but it often takes time. So we draw an analogy often to maternity rights, for an example. So in the UK, maternity leave was introduced in the 70s, but then it was strengthened over the 90s, the noughties, and that over time, that gradual approach has been what has helped, increase women's participation in the workforce. But it has taken that time. It takes time to adjust. When you look at places like the Netherlands, they did take a similar approach. So they started with maybe more voluntaristic standards, then moving to obligations perhaps on larger employers to undertake certain things can help people, which then sort of got expanded and normalized, socialized across the workforce. So that would be the first thing. And I think the sort of on the point about political instability, I don't know if I see it as much of an issue with political instability so much as the way that we kind of do policy in the UK. I think our system is really well geared. It's fantastically optimized for trying lots of different things. So we are brilliant at setting up pilots and trying lots of little local initiatives and taking sort of learnings from that. What we're not brilliant at is scaling stuff beyond that initial pilot.
So a very small proportion of the things that are piloted turn into fully scaled.
Exactly. And I think sometimes things do need a bit more time to bed in, particularly when you're introducing big changes.
It's interesting, the ones that, the other example that's held up around this is auto-enrollment, isn't it? And that's much more enforcement driven. And yet, it's one of those things that now you look back a few years, it's eminently sensible and everybody does it. And this is different to that, but you're quite lucky if it's almost like you're quite lucky if you're one of those, if your thing is one of those things that becomes a universal like that. But I guess what the kind of Keep Britain Working Review's contention is that this is just so important and so costly right now that this should be up there. I guess so let's go. And relating what we were talking about here, the caseworker management and caseworker processes to this. That's obviously you mentioned it's a core part of the Keep Britain Working piece. How are you? I guess what are you seeing coming out of the work that we're doing together, and what are your hopes for how that might influence some of that Keep Britain Working agenda? Now we're into the implementation phase rather than the review phase.
So we know that the Keep Britain Working Review has set out an ambition to expand this kind of case management model of support through what it calls its healthy working life cycle. Where I see this work fitting in is on that first point about articulating the principles of what an effective case management approach looks like, building on the best evidence we have. And I think that's the really important point, because there is lots of evidence about this works in this context, this works in that context. I think the point of this work is to try and draw all that together and kind of pull out the things that are, well, we know this, and this are the key elements of what can make an effective model. I think an example, scalable as well. Exactly. This and it's something that all employers can do in some shape or another. So I think that's a really important contribution, because as the Mayfield Review looks to sort of start stimulating more employers to taking on this type of support. It'll be incumbent to work out, well, what are the principles of that support? What are the kind of minimum kind of standards we should be expecting from that type of support? So
like a good example would be something like IPS, which is very provably successful. And yet would be hard to scale to everybody because of the cost. So we're highlighting that, but we're taking out the elements of IPS that are.
Exactly. And IPS often works with people that face like really quite substantial barriers to the workplace, people with drug and alcohol addiction, people with severe mental health conditions, etc. A lot of people won't need the level of intensity that an IPS program provides.
But it draws attention because it's worked.
And government knows it works, and that makes it easier for government to fund and scale. What we want to be able to do is we'll say, well, what is perhaps a slightly more lighter touch version of that, which is applicable to a wider proportion of people, that can be a bit more preventative in its approach, that can inform the sort of service provision that is available sort of subsequently.
And what do you sort of see as the, we were chatting about it earlier, but what do you see as the output of this, and that is a stepping stone to what, if you like?
Well, I think what's interesting is that when you talk with policymakers, both at a national and a local level, there is real interest in working out, well, what would a future system look like? from the starting point of where we are, not some idealized version, but what for you, given the sort of skills and capabilities and institutions and incentives that we have, already, what is the sort of endpoint that we should be driving at?
Yeah.
So what the conversations that we've been having with, for example, policymakers in, mayoral combined regions, for example, is, well, what they've asked of us is, can you articulate what a good, sensible, evidence-based system looks like? And then from that sort of point, can we then build towards building that in our kind of local area, working with our local employer population to provide something from the starting point that we are. So it's articulating a kind of endpoint that we then need to build towards. I think that's the real point of this.
And how do you sort of see us keeping the, if you like, the research wrapper around that, or keeping that evidence base? Because it comes up time and time again. It had in this review, it comes up in other ones, other evaluations as well. This point about fidelity. How do we keep it such that it is evaluatable, if you like, as we go into this sort of more implementation and testing phase? Is it more research programs? Is it a broad? Is it part of the Mayfield wrapper, or how do you see that?
Yeah, it's a really good question. I think I think there's two things, isn't it? Is it implementable and is it evaluable? And I think in some ways they're slightly different. They have slightly different sort of implications. So is it implementable? I think that is a question that we sort of will need to work through with people whose job it is to do the implementing. Because what they will have is they'll have a workforce, in some partnerships existing, and that will inform, well, what version of this can we do over what time scale?
Yes.
So that's the sort of question. I think that will be on a sort of case-by-case basis. On the is it a valuable piece, I think being able to articulate the principles of, well, this is the thing we're evaluating and this is how it's defined, and fidelity to this is really important. That's really important. I think that's what the work is aiming at. But secondly, we also need the timescales to be able to do evaluation. That's the real issue, I think, a lot of the time, is that, often the payoff from work like this doesn't just happen in 1 year, doesn't just happen in 2 years. It often happens over the entire life course. If people fall out at work, then their income is affected up until retirement age. Their health often deteriorates over time if they're not, so particularly if they fall out of social participation as well, they're not participating in their communities as much. So that's the real challenge is, can we sort of give ourselves enough time to evaluate this type of work over enough period to really understand the long-term impacts we expect it to have?
And do you feel that's sort of in a role where, in a world, I guess, where priorities at the government and policy level switch quite quickly? Is that part of the role that you see that the Health Foundation plays, as to almost to stay with it and insist on that longitudinal view?
I think there's definitely a role for building consensus about a direction that we should be heading in. And it's not just the Health Foundation, it's organizations like RAND, it's other organizations that are interested in this space. If we can kind of collectively agree on, okay, this is what we think needs to happen, and this is how we think it can happen, what that can do is help sort of build an environment where the government is less at the behest of, its spending review cycles. It might be able to make the argument more strongly that we need to be able to sort of invest a bit more time in understanding what this works and how it works, rather than writing programs off just after the pilot phase.
Yeah, because things like, I guess the precedent is there for things like IPS, if the evidence is presented in the right way, and which is the role of, as you say, organizations like yours and mine. If the evidence is presented in the right way, and the process of keeping it on the agenda, if you like, is managed by people who are influencing this from those kinds of organizations, then it can make that difference. It can be accepted as a new model.
Yeah, exactly.
Yeah. And so we're nearly at time, but I'll just finish off by asking you kind of where you're going. What are the things that the Health Foundation are working on around this agenda? So we've talked about caseworker, but I know that's not all you guys do, because you have the whole commission. What are the things that you're working on at the moment that relate to this whole wider agenda?
Well, there's a gamut of work that we're working on, but I think, there's some really key things. One of the really key things we're trying to understand is, well, how do we best work with employers to be able to adopt, to support employers to adopt best practice to keep people healthy and in work? And I think the way that we see that issue is it's less about, we know lots of the principles of what keeps people healthy, you know, access to things like flexible working, access, you know, good line management, proper balance between the demands of your job and the amount of control you have over your job. We know these principles. I think the issue often is like, well, how do we scale practice across sites rather than, really trying to understand what works? So that's a challenge that we're going to be working on. And then I think the other sort of flip side of it is, well, what is a welfare system? Because the other part of this is the welfare system. That is, if people can't work, that's often where people end up. So what is a welfare system that supports health and supports people back into work?
Incentivizes the right behaviours.
Exactly. So that's a question that we'll be focusing on, I think, in the coming years as well.
Okay, very interesting. Well, listen, Sam, thank you very much for talking about the work that we're working on, but also the broader work of the Health Foundation. And I'm absolutely sure that the audience of this are going to learn something today, as have I.
Brilliant. Thank you so much, Ben.
Cheers.
Thanks for listening to this episode of the Working Wellbeings podcast. This one was recorded inside a Nook pod, and honestly, it was a game changer. Even in a busy event space, it creates that calm, one-to-one feeling that you can probably hear in the conversation. And if you want to find out more or get in touch with the team, there's a link in the description below.